So we're going to start with talking about some fact versus myth. And these things come up commonly in the clinic. People ask me these questions, or they think this is what occurs. Some of these are true, some of these are false. And by the end of the talk, you'll be able to say which ones are actually true or false. And I'm sure you've heard these before. You need less sleep as you get older. Sleeping through the night is normal. You shouldn't wake up during the night. REM sleep is the deepest stage of sleep. I hear that frequently. And getting less than 6 hours of sleep can affect your ability to lose weight, can cause insulin resistance. So we'll find out if this is true or false. And your best sleep is before midnight. So let's start with how much sleep do you actually need. Now, it is true that as you go down the lifespan, as you get older, you do need less sleep. However, if you see here, adults 18 and over, you still need 7 to 9 hours of sleep. So it doesn't matter if you're 50 or 30 or 80, you still need between 7 and 9 hours of sleep. And this is to feel refreshed, okay? So that answers one of our questions we were just looking at. Now, how much sleep are we actually getting? Now, the National Sleep Foundation will go out and look at what the trends are, do polls with folks. 35% of adults report getting less than 7 hours of sleep per night. So think of it this way. Say you are actually someone who needs 8 hours of sleep, and you're only getting 7 hours of sleep per night. By the end of the week, you've built up a 7-hour deficit. So basically, it's like you skipped one night of sleep completely. So you can't expect to be rested if you build up that kind of deficit. Teenagers, that's a whole another issue. 45% are getting less than 8 hours of sleep, and they're still growing. They usually need 9 to 10 hours of sleep. So this is a problem. Part of it is because they do have a natural shift in their circadian rhythms. They go to bed later and get up later. And as we get older, and more, 60 plus, you start to shift the other way. You start going to bed early and getting up too early. So with what they say, the old, folks in their 90s, they might be going to bed at, 7 or 8 p.m. and getting up at 3 or 4 a.m. And then the consequences. Why is this important? Well, anyone who is tired knows you have a poor quality of life. You have an increased risk of accidents, and we'll talk about that next. It's very interesting. Sorry. Depression, irritability. If you're tired, you're grumpy. All right, cognitive dysfunction and impaired memory. This has been huge. There have been a lot of links with sleep deprivation and sleep disorders causing short-term memory issues and cognitive difficulties. So for instance, the memory clinic here at UCSF, depending on what the patient's symptoms are, we will see them in the sleep clinic to rule out a sleep disorder, which might be contributing to their short-term memory issues or cognitive issues. Obesity, weight loss resistance. If you're sleep deprived, you can't lose weight. It affects the hormones that regulate your weight. Type 2 diabetes, hypertension, sleep deprivation, and a lot of these sleep disorders do cause an increase in these issues. And then it also lowers the pain threshold. So we have patients who have chronic pain. They're being treated by the clinic, chronic pain clinic, and they don't sleep well. Their pain goes up dramatically. We get them to sleep better, and their pain improves. It doesn't go away, but it does improve. What are the dangers? Well, the biggest one is the motor vehicle accidents, because we all drive, okay? The National Department of Transportation estimates that about 1,500 people are killed each year by a drowsy driver. It's about 13,000 for drunk drivers that are killed. So to give you some sort of perspective on that, 71,000 non-fatal accidents, and quite a bit of a $12.5 billion monetary loss. So it's significant. Most accidents, and this won't be a surprise, occur between 12 a.m. and 6 a.m. So whenever you hear about that big rig accident on the freeway that happened at 3 a.m., think sleep. Person probably fell asleep behind the wheel. The other thing to take note, though, is mid-afternoon. A lot of people fall asleep at this time, which is your natural dip in your circadian rhythm. You just had lunch, you're ready for your nap. And so drowsy driving is very dangerous around this time of day. The National Sleep Foundation did a poll about specifically drowsy driving, and it said 1/3 of respondents reported driving drowsy in the past month. This one was scary, significantly higher accident rate occurs over 2 hours straight of driving. So if you're on a long drive, and this was actually really interesting research they did last year, they presented at our conference last year, that if you're on a long drive, you really should stop every 2 hours. Stop, take a rest, eat, get back in the car. They found that once you went beyond 2 hours, that accident rate went way up. And then here's more specifically, it said 60% of, this was the last year's poll, 60% have driven while feeling sleepy. So they're getting a little drowsy, but they're not nodding off. But 37% admit to actually falling asleep behind the wheel. And I can't tell you how many times I've talked to patients, not even with those with sleep disorders, but patients that are just tired and they don't get enough sleep. These are chronically deprived folks. They're getting 4 or 5 hours of sleep per night. They're falling asleep on the road every day. So be very careful out there. So why does this happen? Well, when you're sleep deprived, it decreases your reaction time, your memory, communication, situational awareness. You're not really aware of what's going on around you. Your judgment is poor when you're tired, and also your mood. It increases your irritability, apathy, attentional lapses, and then these microsleeps. So like people will say, well, I just get drowsy, I don't fall asleep. I said, well, does your head bob? They say, yeah. They said, you fell asleep. So that little head bob, you fell asleep very briefly. So in general, stop driving if you have difficulty focusing, you're daydreaming, wandering thoughts, you can't remember the last few miles, yawning repeatedly. Like I talked about, trouble keeping your head up, don't be a bobblehead. There was a state that, I don't recall which one, but they actually had these billboards they put out about not being a bobblehead, don't drive drowsy. Drifting from your lane, the rumble strip, and then feeling kind of restless or irritable. So just get off the road, take a little break. Take a little nap. Even a 10 or 15-minute nap can make a big difference. And there's some major disasters, as you are aware of all these, that have been linked with sleep deprivation and fatigue. So remember the poor decision making, a lack of awareness of what's going on around you. Exxon Valdez, 3 Mile Island, Space Shuttle Challenger, and then the Bronx bus was the most recent. So these are major things that fatigue, sleep deprivation played a part in these major accidents. So am I getting enough sleep? How do you know? So some questions to ask, and these are in your handouts. So do you feel like you've had a good night's sleep? When you wake up, do you feel refreshed? Do you feel better? Some people say, no matter how much sleep I get up in the morning and I'm exhausted. I don't feel any better. Do you doze or drift off and sleep while you're in a movie? You can never see the end of the movie, for instance. Or if I left the room, how many of you would fall asleep? You dim the lights, make it really quiet. Now, it's a little unfair because of our timing, because it's the afternoon, but I'll have patients come in and say, I could lay down on this floor right now and go to sleep, just like that. Well, that's not normal. Do you have a headache when you wake up? Urge to move your legs, uncomfortable sensations in your legs when you're trying to rest or sleep. Difficulty with concentration and memory, like we were talking about before. Irritability, that's a big one, and depression. Do you have trouble staying awake or going to sleep? Do you have trouble going back to sleep if you wake up? Do you wake up gasping? Is someone telling you stop breathing in your sleep? Do you snore? So just kind of think about all those things. How does it apply to you? Now this is something we use, and once again, this is in your handout. It's Epworth Sleepiness Scale. We use this to kind of see how sleepy you are in sedentary situations. So if you were in the, sitting and reading, during the day, how likely would you to fall asleep? Watching TV, sitting inactive in a public place. So you kind of score yourself, 0 being no chance of falling asleep, 3 being a high chance of falling asleep. And here's the results here. If it's over 10, it's considered considerable significant sleepiness. So you can kind of see where you fall in that norm. And what is normal? Fall asleep within 15 to 20 minutes. I'll have some folks say, well, I don't fall asleep in 5 minutes. What's wrong? Well, it usually is 15 to 20 minutes. Theoretically, if you're getting enough sleep and you're sleeping well, it takes you about that long to fall asleep. If you're falling asleep within 5 minutes, we call that pathologically sleepy. It's not actually normal to fall asleep that quickly. Usually it's because you're just not getting enough sleep to begin with, or you have a sleep disorder that's causing you to fall asleep too quickly. No or rare brief awakenings. So when you want to say, okay, I shouldn't wake up during the night, well, 1 to 3 times is actually normal, as long as you fall back to sleep. So if you wake up and you stay awake for a half hour, that's not normal. If you wake up, turn over, go back to sleep, go use the restroom, come right back to bed, go right back to sleep, that's normal. Sleeping 7 to 9 hours, like we talked about before, you feel refreshed in the morning. So then the sleep problems, this one unfortunately got moved over here, trouble falling asleep, trouble staying asleep. You can't get enough sleep because you're staying awake for so long during the night. When you wake up in the morning, even if you feel you've slept 8 hours, you're still tired. That's not normal. Daytime sleepiness, fatigue, and then the functional impairments, once again going back to cognition and memory, and then the mood, irritability, and depression. So what's normal for someone who's 60 or older? We classify your type of sleep by the type of brain activity we see. So theoretically, the faster your brain activity, the more awake you are. So when you're awake, your brain waves are very fast. And stage 1 sleep, I don't know if anyone of you have experienced this who snore. You'll say, well, she said I was snoring, but I was awake. How could I snore if I was awake? Well, that's stage 1. Stage 1, you can still kind of hear things around you. You feel like you're awake, but the brain waves are just starting to slow down. If I was holding something in my hand, I can hold it in stage 1. I drop it as soon as I go into stage 2. So you shouldn't spend much time in this stage. It's a non-restorative stage. It's just kind of a easing into a deeper stage. Stage 2, you should spend about the majority of your time, 50 to 60% of your time in that stage. Stage 3 is what we call the deepest stage of sleep. This is the stage of sleep that sleepwalking occurs, night terrors. Very difficult to wake someone up out of that stage of sleep. And as you get older, unfortunately, this sleep goes away. So after about age 30, you have this slow decline. By the time you're in your 80s or 90s, you may not have any of that type of sleep. REM sleep is about 20 to 25% of your night, and that stays the same across adulthood. So there's no change, no decrement in that. This is what we call a hypnogram. This tells you, you have the time on the bottom. And here's that stage 1 we were talking about. Here's wake. You go into 1. It's like a staircase. Go down to 2, go down to 3. Before we used to put 3 and 4 separate. Now they're together. So each step is a deeper stage until you get down here. And then about every hour and a half to 2 hours, you go into REM sleep, which is this bold line. And then you go back down, and then you go back up. So you see there's these sleep cycles that every hour and a half to 2 hours, you go through your sleep cycles. And you'll notice that the majority of the deep sleep is in the first 3 hours. Okay? And towards morning is when you have more REM sleep. So your likelihood of waking up out of a dream is much more likely in the morning. You have about a 50-50 chance of waking up out of REM sleep in the morning. So let's now move on to the common sleep disorders. These will all be familiar to you. And the prevalence is a little surprising, it's quite a bit. Sleep disorders, sleep-wake disorders affect 50 to 70% of a million people. Insomnia, it's 54% of the general population. And basically they're saying with greater than 1 insomnia symptom, at least a few nights per week. But that's pretty significant when you think about that. So insomnia by far is the most prevalent sleep disorder. Then we have obstructive sleep apnea, with at least 20% having mild, and then it drops as we go to moderate. Restless leg syndrome, 7 to 10% of the general population, and this does increase with age. You have circadian rhythm disorders, that's more like shift workers, and then there's also periodic limb movements, which I'll have a whole section here about, that has some similarities to restless legs, but some very distinct differences, and it also gets more prevalent with age. So by definition, insomnia is a number of things. It's trouble falling asleep, or trouble staying asleep, unrefreshing sleep, so you've slept all night but you're still tired, The main thing is it has to be associated with daytime impairment or distress. So I do have folks come in once in a while and they'll say, you know, my friend gets 6 hours of sleep, so I get 6 hours, and I feel exhausted. Why are they okay? You know, it's like, well, you have to know your number. Everyone's a little different. 6 to 10 hours of sleep is the normal range for adults, but the average, of course, is more like 7, 8, 9 hours. So if you're getting 6 hours of sleep and you feel wonderful, I'm not going to tell you to do anything different. You know, if you're staying awake during the day, you're not having any problems with memory or cognition or anything like that, we're not too concerned. So, insomnia treatment. We really base this on more behavioral approaches. Cognitive behavioral therapy is a major way to approach insomnia, because what happens with insomnia, and those of you that have insomnia know this, you get kind of stuck in this negative loop. You know, you start dreading going to bed, and then you go to bed and you're lying awake and you're ruminating and you're worrying about things, your mind's racing and you can't get to sleep, and you start anticipating that you're going to have a horrible day the next day, and it just kind of keeps going down, 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 down. So the CBT is how to stop that from happening. So reassuring yourself, for instance, I will be okay, I'll be tired, but I will be okay. Those kind of things you work on. Relaxation techniques, meditation. Some people can't meditate. Some are more physical. They like to do the progressive muscle relaxation or yoga. They can also do the deep breathing exercises. Mainly, you're trying to distract yourself from focusing on those busy thoughts. Okay. Stimulus control means controlling your environment. It's quiet, cool, no TV in the room, no computer in the room, no laptop in the room, no phone in the room. Sleep hygiene, and we'll go over that in more detail. And then possible short-term use of sedatives. I will be honest, I'm not a big fan of sedatives. I'll go over them briefly, but you preferably do not want to take these on a long-term basis. So good sleep hygiene, and everyone benefits from this. Get 7 to 8 hours of sleep per night. Maintain a regular sleep-wake schedule. Arise at the same time each day. This is huge, because when people retire, they tell me, I got up at 5 a.m. for 30 years. I want to sleep longer. I don't want to be on a schedule anymore. And that's great, but if you have insomnia because you have this very irregular schedule, then it's a problem. Because a lot of times they'll say, yeah, I slept great when I worked. Since I retired, it's been terrible. So you've got to really keep a regular bedtime, you know, 9 to 10, 11 to 12. Just, it has to be a narrow range, and get up at the same time every day. Don't drink caffeine close to bedtime. Some people are very sensitive to caffeine, so you may want to even cut it out after noon or 1 o'clock. No nicotine, especially in your bedtime. Alcohol is interesting because it helps you get to sleep, but once it metabolizes, it actually irritates the brain. So it causes very light sleep, and it actually decreases your REM sleep. So it's not a good idea to drink a lot before bed. Regular exercise. Exercise is showing to be very helpful to improve your sleep quality and help with insomnia as well. And then minimize any kind of issues in the room. You know, I have folks that will sleep with their pets, and as long as they don't have insomnia, I don't care. You can sleep with, you know, an elephant in the room. But if you have pets that are waking you up, that's something that needs to be addressed, and you can't get back to sleep. So I alluded to this a little bit earlier. Do not sleep with your phone. I think they're going to come up with a new sleep disorder for this, because in the sleep lab, when we do a study in the lab, we have a camera so we can see the patient, verify their body position. And I can't tell you how many times I've reviewed a record and had to see this bright light go on and the person's looking at their phone. It's 2 a.m. It's like, oh, what are you doing? So yeah, it's not a good idea. First of all, what is that important that you have to check your email at that time? Nobody should be texting you and they should be asleep. And actually, that bright light shuts off your own melatonin. So they did a study measuring, they do it with saliva, they measure melatonin secretion. And melatonin is supposed to start secreting when it gets dark, and when it gets light, it goes away. It's related to light. So if you have this burst of light in the middle of the night, it actually turns off, really diminishes your own melatonin. So if you have insomnia, don't be doing this, especially. Don't look at the clock. Not reassuring. Typically, people look at the clock and say, oh, I've only slept 2 hours, and I only have this much long to sleep, and I have to do this tomorrow, and then they get into that spiral again. So If you get one of those that looks at the clock and says, oh, I have 2 more hours to sleep, that's okay. But if it worries you, don't look at the clock. Don't have a TV in the room. Once again, don't read on tablets or the Kindle Fire, something that has a backlight that's going into your eyes. Same thing as a phone, it's going to start shutting off your melatonin and you won't be as sleepy, you won't be able to get back to sleep as easily. And there actually is a blue light filter, and I put this in your handout. You can get it for your phone and your computer, it's free, just get F-Lux. I haven't seen it for the Kindles yet, but it blocks the blue light, because that's the culprit. The blue light is what shuts down your melatonin. So they also sell little orange goggles, but I don't know if you really want to wear those in the middle of the night. So things to consider. Know yourself. Are you an owl? Are you a lark? This is important to know. If your circadian rhythm is a night owl and your bedtime's at 12 a.m. and you're trying to go to bed at 9, you're going to have insomnia because that's not your natural time. I had this patient who was really cute. He was usually going to bed at 1 a.m. He has a new girlfriend. She goes to bed at 9. So he's trying to shift over to her schedule. She doesn't even live anywhere close. She's in Washington State. And I'm like, why are you doing this? She's not even close by. Because he's basically started having insomnia since he changed his sleep cycle. So know yourself. Know when your natural dip is and when it's time for you to go to sleep. If it is someone who can't shift and go get it, say you have to get up at 6 a.m. every morning and you can't fall asleep till 12 or 1 a.m. Well, that's when we do use melatonin and bright light in the morning, and we can help shift their circadian rhythm. So there's ways we can actually adjust your rhythms. How do you sleep away from home? This is a really good question to ask for a couple reasons. One, if you sleep really good away from home, that's a major sign. That tells me that it's more of a stress-related thing. You're not broken. You can sleep great away, but at home, the insomnia returns. So that's actually a nice thing to know about, because that's fairly easy to fix. The other thing I have is I'll have people say, well, I don't know. I haven't taken a vacation in 6 years. And it's like, okay, I think you need to take a vacation. So if you don't know how to relax and tone down and in your general life, you're probably not going to be able to do that well when you're trying to sleep either. Don't lie awake in bed for long periods of time. Get out of bed and do something relaxing. Once again, think about nighttime. There's no distractions, it's quiet, it's dark. You can sit there and think, and stress and get into that loop. Is that the time to be doing that? No. So in order to distract yourself, get those things to calm down, get your mind to calm down, get out of bed, find something that relaxes you. And sometimes that's hard for people to do because they don't know what relaxes them. If you read something dull. Don't read an interesting novel or something you're really excited about. Read something, rather boring for yourself. So, in general, there's no quick fix. We're looking for gradual improvement. When we treat someone for insomnia, each follow-up, we're looking for gradual improvement. And you do see it, but you have to be patient with it. This is actually something that's a big deal. There isn't just one thing that's going to take care of this problem, and that's the individual part. Everyone's different on what combination of things is going to work for them. Some people say they can't get out of bed because as soon as they do, they get too alert. Some people say they read and get too alert. So you have to come up with a step-by-step. Every week or two, you add on a new change. And because I have people say all the time, oh, I've tried that, and nothing works. Well, when they try something, it's usually for a couple days, and 2 to 3 days, and that's not long enough to really assess if something's going to work. You really need to try it for about a week or two until you kind of can assess it. This is big. If you don't sleep well, don't make it a disaster. Don't define your life by insomnia. Okay, you will be okay. You're not going to feel real good. You'll be tired. I completely agree. You're going to be grumpy, tired, but you'll be okay. And you've got to start drilling that into yourself, that you will be okay. All right, so here's some medications. The reason I'm not a big fan, and those of us in our clinic aren't in general, is that any of these medications, and this goes for over-the-counter medications too, like Tylenol PM, you build up a tolerance at some point, which means you have to take more and more and more to get the same effect. And the other thing is, of course, they have these side effects, and like for Tylenol PM, you can be very groggy the next day. It lasts in your system a very long time, has a long half-life. I'm sure you've all heard of the Ambien. These, Zolpidem, Zalopon, and Zipclone, are all in the same family of medications. If you have to take something, these are a little better because they don't change your sleep architecture, they don't change the brain waves, and they don't change your breathing. The Relmeltion, you probably haven't heard of it, it's been around for a while. This is a melatonin analog, so it isn't a sedative, it doesn't knock you out, but it kind of helps ease you into sleep. And then Doxepin is an old drug that they now have released as with a new dose. They're really approved for only short term. These are great to take if you're jet lagged for travel, if you've had a major stress in your life, taking it briefly, taking it every so often, once or twice a month maybe. But really, when you start taking it every night, you start taking more and more. And I've had some scary combinations come in. I've had patients on very high doses of multiple medications that if I took their cocktail, it would kill me. It would stop my breathing. But see, they've been taking it so long, they've built up this tolerance. And so it's really hard to get those folks back down off them. It's tough if they're up at those real high doses. But once again, they're getting desperate to sleep, and you don't want to get into that position. So the next one is obstructive sleep apnea, which I'm sure you all heard about. The definition is repetitive episodes of complete or partial reduction of airflow. So the airway is partially or completely closing. Usually there's a drop in oxygen with it. The EEG, which is the brain waves, there's usually the brain waves speed up, so the person wakes up for a few seconds. And surprisingly, the person typically has no awareness of this happening. Recently, I've had a few patients who were in the hospital for other conditions, and they live alone. And they were told by the nurses or doctors that they had sleep apnea, because no one had told them that before, but they were being observed in the hospital. Symptoms. The classic symptoms are the excessive sleepiness during the day. Fatigue, unrefreshing sleep. They say, I'll sleep 12 hours and I'm still exhausted. Doesn't matter. They have a headache when they wake up, and this is related to their CO2 levels, carbon dioxide, because when you don't get your oxygen's going down, your CO2 is going up. And so when you wake up, you have this headache. It usually goes away without taking anything, but it is there. Nighttime sleep symptoms, once again, awakening with gasping, choking. Often they don't know they're doing this. I have a lot of patients who present with insomnia. That's their main complaint, but they really have sleep apnea that's causing the insomnia. So when we treat the apnea, they do great. Waking up frequently, using the restroom frequently during the night. The reason for this is when you have an apnea, your blood pressure spikes, and your brain thinks, oh, I need to get rid of fluid. Blood pressure's high. So you end up using the bathroom a lot. And once again, they're not aware of waking up. So, bed partner. They complain about the loud snoring, that the person stops breathing in their sleep. It's scary to watch someone you care about do this, gasping. It can be quite dramatic, so it can scare people. And then the other annoyance is they fall asleep. You go to the symphony and they're sleeping. You go to the movies and they're sleeping. It starts affecting your life because they can't do as many activities because they're too tired. So what actually is happening, as you fall asleep, all your muscles relax. And in some people, because they have a narrow airway to begin with, the airway gets even narrower. And when I'm talking about the airway, I'm talking about right behind the tongue. It's pretty high up. So you can't even feel back in there. They can't get enough air, the oxygen level drops. They have that gasp and the brain wakes up briefly. And when I say when the brain wakes up, it's literally about 3 to 5 seconds. So you're not conscious of it. And then you go back to sleep. And you do it again. What this does to your sleep architecture, how I was showing you that nice little staircase? Well, it does this. You're just in and out, in and out, in and out, in and out. So every time you wake up, even for 3 to 5 seconds, it's like a stopwatch. It goes back to that stage 1 and back to stage 1. So you don't get hardly any deep sleep at all. So some physical characteristics, things we look at in exam. Obesity is definitely, there's a high correlation with obesity and sleep apnea. But I think what people don't realize is that these things, a recessed chin, retrognathia, and micrognathia, small jaw, you see in this young woman how her chin is very small and recessed. You can have very severe sleep apnea with this anatomy because what's happening as the jaw relaxes, it pushes the tongue into the throat. So some of my most severe patients have had this. They haven't been obese, but they've had this kind of anatomy. Some people do have a very large tongue. Once again, the tongue relaxes and falls into the throat. Thyroid, low thyroid, if it's not treated, can actually cause sleep apnea. So if that hasn't been checked, we usually check that. If they're taking too many sedatives, like I said, that cocktail, that can cause some breathing problems. Valium is well known to be a muscle relaxant, so it really causes apnea to be much worse. And post-menopause, women shoot up on the number of cases of sleep apnea, quite dramatic. So what's closing the throat? So here we have, this is your nose, this is your sinus cavity, this is your tongue. The soft palate, your hard palate, you can feel with the roof of your mouth, and then back there's the soft palate. So here's the airway. And you can see how that tongue is just kind of falling in the soft palate. And that's what's causing that closure. So sleep testing, what do we do? This is a very busy slide. Don't worry about it too much. I'll just kind of summarize it. We only really do sleep testing on folks that we believe have sleep apnea. They have nocturnal seizures. They have abnormal muscle activity. If you have pure insomnia, we're not going to torture you with a sleep study because you don't have to prove to us you can't sleep. We only do a sleep study on someone with insomnia if they also snore, if they also have rhythmic twitching or kicking. There has to be something else going on for us to test them. But sleep studies are the only way to really diagnose sleep apnea or periodic limb movements. You just have to. There's no other way to know what the person's doing. So don't these guys look happy? This is a home sleep test. It looks just at breathing. It's a great device because if you do have trouble sleeping away from home, this is a good option to have. It really only screens for sleep apnea, however. So if we're suspecting any other disorder, it's not going to be able to pick that up. But it's similar to this. It has a lot of the same connections, looking at the chest movement, air movement through the nose and the mouth, snoring microphone. Our device picks up, estimates the decibels for the snoring, and it's always kind of fun to look at that graph on the bottom because sometimes it's very, very high. And this is the polysomnogram where we do the in-lab test for our particular lab. We actually have our lab in a hotel, so it's actually very comfortable and private for folks. But they have all these wires over them. This is what we look at. And these are eye movements and brain waves. Okay. Down here, as we move down, we have airflow. So we're measuring air through the nose and the mouth. And you can see you kind of breathe, breathe, and then flat. And then they start up again and breathe and breathe and breathe. That's an apnea. Now look down here. This is their chest and their abdomen. They're trying to breathe. Trying to breathe, breathe. It's getting harder and harder to breathe. These are getting bigger and bigger and bigger and bigger. And see this noise here? That's when they wake up. So that's what it looks like. You can also see on the bottom here, the oxygen level is dropping as this is occurring. This is someone who has repetitive or cyclical apneas. They stop breathing, recovery breath, stop breathing, recovery breath, stop breathing. I mean, you can just see it just happens over and over and over and over. So quite dramatic. And once again, they have no idea. I have some folks, they'll stop breathing 90, 100 times an hour. They don't have any idea they do this. So as we were talking about before, the home test is great for folks who insomnia, or and we think they have sleep apnea because they'll be better at home. We don't do this home test on someone who has a history of cardiac disease, arrhythmias, because all we get on this kind of test is the rate, heart rate. We don't actually get an EKG. So if somebody has some sort of cardiac history, we will be doing a lab test. It is more preferred by insurance because it's cheaper. It's easier to do. It can be faster to schedule it as well. Usually we can do this within a couple weeks. And this is the little device. You just kind of come in, the text shows you how to put it on, take the little case, go home, put it on before you go to bed, drop it off the next day. And this is a tracing, just to give you a comparison of what the home test shows us. So this is that airflow signal, the chest, and then we have the oxygen level, and then we have the heart rate. So simplified version. So you can see we just are looking at breathing. And then this kind of just goes back into what we were talking about. You know, there are pros and cons. And this is something we talk about with the patient. You know, what do we really need? We're not going to put them through a test that they won't be able to sleep. You know, we're going to look at the whole picture. What test is best for which person? Disadvantages. You know, the lab, obviously you're being monitored. The tech can fix the device. We do have about a 30% fail rate with the home tests that we have to repeat because a sensor doesn't work. So that is a problem. The American Academy of Sleep Medicine actually only recommends the home test for people who you suspect have moderate to severe sleep apnea. So those folks that you feel may be more subtle, they usually need a lab test because it's more sensitive. Treatment for everybody: weight loss, positional therapy, avoid alcohol. Positional therapy, classically, sleep apnea is worse when you sleep on your back because when you're on your back, that tongue falls into the throat. Surgery in general is about 40% effective, not great. If you're mild, you could have a cure. If you're moderate or severe, surgery is not going to cure you, unfortunately. So that's something that is available, but we tend to be a bit more conservative about that. The oral appliance is actually something that's gotten very good over the past 5 years. It's made by a dentist, and what it does is it keeps that jaw forward. Remember how I was saying how the tongue falls back? Well, if we pull the jaw forward, the tongue comes forward. So that keeps the throat open. And it actually can be about 65 to 80% effective for mild to moderate apnea. I have a lot of people who won't come in for a sleep evaluation because they're afraid we're going to throw a mask on everybody, that everyone gets CPAP. And that's not true. It just depends on what we find, how severe it is, your comorbidities, how healthy are you. And you could be a good candidate for the oral appliance. And then we have the CPAP, continuous positive airway pressure. I'll go into that a little bit more. That's the mask you wear. And the reason we like it so much is it is 90 to 100% effective. And that's hard to do in medicine. There aren't that many things that are that effective. So as we go through, mild apnea, give you some numbers. 5 to 15 times an hour, you stop breathing. That's what mild apnea is. And a lot of people say, well, that sounds like a lot. Well, if you go look at the research they've done over the last 40 years, if you have mild apnea or even below that, there's really no increased risk of morbidity or mortality with mild or no apnea, as far as, like for instance with snoring. Now, there's some newer stuff coming out linking snoring with increased atherosclerosis in the carotids. So these are some new things because it's causing an inflammation cascade. So these are some new things that we're starting to learn, that even with possibly snoring, which also would translate into this mild apnea, that you're starting to have some inflammation going on, causing some increased atherosclerosis. So this is going to be interesting to watch as they look at that more. Great options for mild apnea, sometimes just losing weight, sometimes just sleeping on your side. The oral appliance and surgery. I don't usually push CPAP for someone who's mild unless they've already had a heart attack or stroke or an arrhythmia. But if you're just, if I get someone who's in his 40s and he's healthy and has mild apnea, we'll work on the behavioral things first. This is something I find very, very interesting. Some people only stop breathing in their sleep in REM, when they dream. They'll be almost perfectly normal, and then they hit that stage of sleep and it's just repetitive apneas. So remember that picture I was showing you where we just kept getting those apneas over and over. And I see this especially in women, postmenopausal women. This is just starting to really be researched. We don't really have an answer for this. But overall, if you look at their numbers, it's like borderline normal. But if you look at REM specifically, it's severe, moderate to severe. It's really significant. And these are folks that come in saying they're tired. So what do? Depends on the symptoms, but if someone comes in and they have this REM-related sleep apnea and they're exhausted, then I will try the CPAP on them. Say, just try it for a couple months and see if it helps. 90% of the time it does. But there's really no consensus in the field of what to do with these folks because, like I said, overall the number is mild. But if you're spending, almost a quarter of your night not breathing, that's a problem. So here's one of those pictures again, like we saw before. This is your sleep stages. Right here, this is your oxygen level, okay? And each one of these little marks is when you stop breathing. So you can see, here's REM, the dark lines, bolded lines, and look at here. And this is with no change in position. The person has not moved. The only thing that's happened is they've gone from non-REM to REM sleep. So that's the kind of thing we're talking about. Moderate apnea, you stop breathing 16 to 30 times an hour. This is where we get more aggressive with treatment because you do have an increased risk of heart attack and stroke. You do still have the option of surgery, oral appliance, or CPAPs. If you're low moderate, the oral appliance can work quite well. So we can still use this as an option. But CPAP is still usually recommended first. In fact, some insurance companies won't pay for the oral appliance until you've tried and failed CPAP, if you're moderate to severe. So it depends. And then severe is over 30 times an hour. That's every other minute. So when you have an apnea, and it's like someone's just jumped out of the bushes to choke you. So what happens if that occurred? Your heart rate would go up, adrenaline, cortisol, blood pressure shoot up, heart rate. You'd be scared, right? But what if that happened every other minute? That's what these people are doing at night. And this is that part of that link with heart attack and stroke. Very hard on your cardiovascular system. And like I said, I've had folks 90 to 100 times an hour stop breathing. First option is CPAP. Oral appliance is only about 25% effective for severe, so we don't usually start with that. And once again, surgery is about 40% effective, so if you have surgery, you usually will still have to use CPAP. So it's not curative. So what does the CPAP do? So it's continuous positive airway pressure. So the air goes through a mask through your nose and just props the throat open, keeps it from collapsing. It's just room air. It's not extra oxygen. It's not a ventilator. People are worried that their muscles will get weak. It's not true. You do all the work of breathing. In fact, they're using CPAPs in preemies now routinely instead of putting them on ventilators because then they want the babies to be strong. So it doesn't affect your breathing capability. It's safe to try. I always have this where, I don't have anyone ever run in and say, I want a CPAP, give me a CPAP. That doesn't happen. So it's like, okay, just try it for a few months and see what you think. If you start saying, well, I have to wear this the rest of my life, I tried to get you not to go there. Let's just see, how do you feel? Do you actually feel better? The masks are like shoes. Until you try them on, it's hard to tell what's comfortable. But there are a lot of comfort features that have come out in the last few years. Heated humidifier, it lowers the pressure a little bit when you exhale, makes it a little easier to breathe. So here's some masks, some different ideas that are out there. They're finally making them for women. They're in pink. I don't know why they chose pink. But this is the first time they've actually made masks specifically for women. This one cracks me up because she doesn't have sleep apnea. I don't know why they picked this model. I mean, I know why she's very pretty, but it's just silly. But this is actually a cloth mask. So like people who have allergies to the silicone, we can actually use the cloth mask. And then these are the CPAP machines. So you can see the size compared to the little 8-ball. So they're pretty small. These are the oral appliances. So they look like retainers. And they have an adjustable thing on the side where they will adjust in millimeters very gradually and make your jaw go forward. And you only wear them when you're asleep. So there's different ones. Medicare does pay for these now. They have one specific one they've chosen. And then these are things that are kind of out there. This one's called Provent. It really hasn't panned out to be as great as we thought it would be. It's basically like wearing 2 Band-Aids on your nostrils, but it has a valve. So when you inhale, it's easy. When you exhale, it has some back pressure. The idea being when you have extra pressure in your throat, it keeps it open. Insurance doesn't cover them. They're a prescription. And I only have a couple of people who have used these long term, so they're not real reliable. This is something the same company came out for snoring. It's over the counter. I don't know how it works. I have a couple of people I have trying it, haven't heard back from them. Same idea, creates a little bit of back pressure, so hopefully decreasing the snoring. These pillows, these contoured pillows you may have seen, What they do is they help with positional therapy, and they've actually shown in CT scans, and Stanford did a study about 10 years ago with these, because my husband was a subject, because he has a mild apnea, and it shows that it opens the airway. So when you're on your side, you don't want to tuck, that closes the airway. This opens it up. And then side sleep. You have to make it uncomfortable to be on the back. Use a ball shirt, take tennis balls, put them in a sock, safety pin the sock to the back of your shirt. That makes you can roll over, but you have to stay on one side or the other. If you only use one tennis ball, what happens is people kind of do this half back, half side sleep, and then they'll still stop breathing. So it really has to be completely on the side. I had a cute lady who was using one of the, the lemon, you get the juice, lemon juicer. She had put it on. It's like, oh, that wouldn't be very comfortable. Okay, what doesn't work, but I wish it did? The Breathe Right strips are great for nasal congestion, and they can decrease snoring. However, they're not doing anything about this part of the airway. So unfortunately, they don't do anything for the apnea. This is funny. It's a little thing that zaps you and wakes you up so you'll stop snoring. Well, I don't know what that's supposed to do except for aggravate you. This thing, I don't have any idea really the way it's supposed to work. It's like a little nose clip. But really, what's it supposed to do down here? It doesn't work. And then a lot of people will try these chin straps because they figure, well, if my mouth is closed, I won't snore or I won't stop breathing. Well, unfortunately, yeah, that tongue can still fall back and you'll still stop breathing. Somebody's making a lot of money on these. This one really is irritatingly funny. It shows it has a little cartoon that goes with it, and they spray it, and you see your soft palate shrink. It's like, well, if I sprayed it on my nose, would that change the shape? I mean, that's basically what they're saying. So, doesn't work. And then this one I actually saw in a store, a little bopping thing. Though they're probably getting bopped anyways. They don't need it. All right, so restless leg syndrome, and it's starting to be known now as Willis-Ekbom disease, okay? So I highlighted this, and I'm just going to have you focus on the urge to move the legs begins or worsens during periods of rest or inactivity, partially or totally relieved by movement, only occurs in the evening or night. It happens when you're awake. You're aware of this happening. This is causing insomnia. This is not leg cramps. There's a familial link, becomes more severe with age and pregnancy. Ferritin, which is not typically checked, it can be a direct link with that. And usually below, and I'll talk about that in a sec, below 75 micrograms. So we like to check a ferritin level. It's worsened by caffeine, nicotine, and antihistamines. So we found that below 75 micrograms, 25 is the low of normal. So this is in the normal range. But if your level's below this, you can have more RLS symptoms. And if it is, we put you on ferrous sulfate for a few months, retake the levels, see how you're doing, and people feel better. It may not completely get rid of the symptoms, but it's dramatically improved. Of course, you can have the nausea, black stools, constipation with that, so eat lots of fiber, don't take it on an empty stomach. FDA-approved medications, there's Mirapex, Requip, Nupro. The problem with these is they have some pretty significant odd side effects, sudden sleep attacks, episodes during the day. And these aren't dose specific, it could be any dose. Hypotension, compulsive behaviors. There was a gentleman who was buying doll clothes on the internet, thousands and thousands of dollars, and then finally took him off the med and the behavior stopped. So that's a significant risk. So the other thing people get scared about is these medications are used for Parkinson's. But for Parkinson's, they use them at very, very high doses. When we use them, it's very tiny doses. So there's really no link between Parkinson's and restless leg syndrome. And then there's a new one, gabapentin, that's come out in a new formulation for severe RLS. There's other ones used, and it depends on the person. If we use, like oxycodone or the clonazepam, it just depends on the person if they've been already on that or have not. This one, I want to make sure the difference between this and restless legs. Periodic limb movements in sleep occurs when you are asleep. You actually are not aware of this happening. Your bed partner might complain that you're kicking them during the night. Very predictable movement every 20, 30 seconds. This person will twitch or kick. It can be very subtle. If you're looking at the person, you may not see it. But when we're looking at the electrodes on the sleep study, we can see these little bursts of activity. I have seen people who look like they're marching in bed. Literally, their legs are just going back and forth and while they're sleeping. So here's, once again, that sleep study. These are the leg movements, little bursts. We only worry about this if it's causing sleep disruption. So if we go through and we find that it's waking the person up frequently during the night and disrupting their sleep, that can cause you to be tired, then we do treat it. If it's not, we don't actually treat it. Antidepressants can cause these movements or make them worse. If there is no sleep, like I said, disruption, we don't treat it. The bed partner will often ask us to treat the person. And that's kind of a quandary, because it's like the person's okay, but you're treating it for the spouse. So one thing to consider is getting a king bed with 2 separate twin beds on top. So when they're moving, you don't feel it as much. But we do, in general, treat it with the same medications as RLS. So once again, you have those potential side effects. This is something that's not common, but is significant in the elderly, REM Behavior Disorder. Basically, patients are acting out their dreams. It's very violent. They remember trying to save somebody or fight somebody off. It tends to occur more in elderly men. And what's significant about this is its link with Parkinson's disease. This is frequently a precursor to Parkinson's. You may see this symptom happen about 10 or so years before the other symptoms of Parkinson's appear. And keep in mind, it's different than sleepwalking. It's happening in REM sleep. In sleepwalking, if you wake them up, they have no idea why they're standing there. Like that little girl was driving the other day, I think, on the news, a 10-year-old got in a car and drove around. She didn't even remember anything or why she was driving. So it's a very different scenario. And like I said, it's violent. It tends to be very violent. I've had people say they've picked up the mattress with their spouse on it and thrown it across the room. I mean, it can be quite dramatic. I had another patient who put stuff between them, like a big bolster of safety pillows, so he wouldn't hit her. And then you treat it with clonazepam, actually, and that's what we use for a lot of the parasomnias. It works quite well. So back to our quiz. You need less sleep as you get older, myth. So after about 18, your sleep need is the same. What changes is that you can't sleep as well, maybe because of pain, medications you're on, other medical conditions. And of course, you've lost that deep sleep, or most of it. So when you're sleeping, you're awakened easier. You're not as deeply asleep. I should sleep straight through the night. Nope. 1 to 3 times is not normal as long as you're falling back to sleep. I had a cute patient yesterday, and he said, I wake up at 2 a.m. And I'm like, well, do you fall right back to sleep? He goes, yeah. I'm like, fantastic. And it's like, so you don't want to try, even the sleep medications we give you usually aren't strong enough to knock you out for 8 hours. I mean, you really don't want something that strong. So it's unrealistic to expect that. REM sleep is the deepest stage, as we talked about. REM sleep is a very active stage of sleep as far as your brain is concerned. And think about that. When you're dreaming, it's like you're involved in something. You're aware of what's going on. You see things. It's just like when you're awake. So the brain activity is the same frequency, just as fast as it is when you're awake. Stage N3 is the deepest. They're very slow brain waves. Children have a ton of this deep sleep. So if you've ever picked up your children or grandchildren when they're just falling asleep, they're like lump, that's stage N3. And that's where sleepwalking and night terrors occurs, and that's why it's hard to wake them up out of that stage. Most people need 7 to 8 hours of sleep. Yes, 6 to 10 hours. The key is knowing what your number is. If you're getting 7 hours of sleep and you're tired, get 7.5 for a few weeks and see how you feel, and kind of bump up. And getting less than 6 hours of sleep can affect your ability to lose weight and cause insulin resistance. Yes. In fact, studies have shown if you get less than 5 hours of sleep, you actually score the same as someone who's legally drunk on reaction time, cognition. It's pretty scary. The military has done a lot of studies on that. And your best sleep is before midnight. Myth. Depends on what time you go to bed. So your deepest sleep is in the first 3 hours. It doesn't matter when that is. So if you go to bed at 9 to midnight's your deepest sleep. You go to bed at midnight to 3. And once again, the owl versus larks. And those are my boys. So wishing you all good sleep. Thank you.